If you want to take over this chair, yeah. I'm gonna sit over here in the corner. It won't creep you out of here, right? Okay, I still like being in front of the camera.
No,
It's too much. It's too much for the little name. I should text everyone so we'll get started.
And
Promptly.
are you Guardians guy or whatever? Anyway, it was an article on football. And just, you know.
It's a volunteer opportunity.
These from Dave's so fun.
The first time looking at it. That was good. Oh, yeah. Yeah. Actually, I'm probably. Yeah. No, I mean, if I'm not there, I'll go. I just try to fill it out.
Very colorful.
Yeah.
Basically, I'm trying to get the two messages for people.
Yeah.
Tell me now. Get this kind of.
I see.
Otherwise, we can just be like.
Oh, okay.
Individual seconds later.
I go.
You can decide if it's.
Yeah. Colin, we'll be talking about it when we decide to scurry out. But if for some reason the first happens, or he's not here, so I just like closing out all the programs and then turning off the monitor.
Okay. Sounds easy enough.
Just to make sure you're
Yeah, that's okay.
anything else important.
Yeah. No, I did not do that. No, I was gonna do it. You're not much.
Oh, are you joining this?
Yeah.
Yeah.
All right, guys, we are gonna get started because Intern Report features two presenters. So to make sure both Ian and Nithya have enough time to present, we're gonna get started promptly with Nithya kicking us off. They're the first Intern Reports of the year. Yay. So give them love, give them support. If they have questions for the audience, don't just deadpan and stare at them because it's uncomfortable. I'm uncomfortable with silence, but they may not be. And without further ado, I'll let Nithya take it away.
Thank you. So I feel like most of us have met, but I'm Nithya. I'm an alpha prelim. And I have an interesting case for you today. It was put together by Chris and Colin, so thank you. We'll start with a one-liner. So we have a 56-year-old male. He has a history of hypertension and polysubstance use disorder. And he presented to the ED with headache, blurry vision, and chest discomfort. So if you were taking history for this patient, what more do you want to know about him?
When did this start?
Yeah, good question. Anything else?
What
Good
substances?
Yeah.
Is he taking his antidepressant medication?
Very good question. Yeah, he's not. Anything else?
Has this ever happened?
Yeah. All great questions. So he's been having the symptoms for hours. He thought he was withdrawing, so he came in. For his headache, he describes it as 9 out of 10 pounding. For his blurry vision, it's like cloudiness. And his chest discomfort is more pressure. It's non-radiating. For his drug use history, he uses opiates, cocaine, tobacco. Last used it 1 day ago. For his medications, he has amlodipine prescribed but does not take it. His review systems is negative for shortness of breath, hematuria, and any other neurologic deficits. And then for his social history, he's unhoused and he's had several admissions for withdrawals in the past. He's interested in rehab and initiation of methadone. So next, what are you interested in seeing on his physical exam? What would you take a closer look at?
Vitals, blood pressure.
Vitals, blood pressure, yeah.
They can look at his eyes.
Yeah, his eyes, yeah. We do a fundoscopic exam, hopefully.
Everyone's got it in their pockets of
Yeah.
their coat.
So his vital signs, he has a blood pressure of 224 over 132. He's not tachycardic. He's satting well on room air. He's afebrile. Overall, he appears uncomfortable. And yeah, you would do a fundoscopic exam and you would see some mild arteriovenous nicking. So if you see here, this is the vein, and then this is the artery. It's kind of crossing over. Actually, you can't see my cursor.
If you
Oh,
it's like an extended screen.
is it? Oh,
Yeah.
right there. Okay. So that's the artery. This is the vein. When you see the artery, which has very high pressure crossing over the vein, it kind of pinches it closed. So that's called AV nicking. And then they saw no papilledema, which means no swelling of the optic disc. For the cardiac exam, regular rate and rhythm, laterally displaced point of maximal impulse. On pulmonary exam, he has mild expiratory wheezes bilaterally, and then no focal neurologic deficits. So the next thing I want to go into is a differential diagnosis. What I like to do is go through the organ systems and think about it that way. So we can start with neurologically, what's on the top of your differential in general for this patient? Really high blood pressure, some eye changes, some chest discomfort.
I
What do you
see.
think? Sorry.
Subarachnoid.
Yeah. Subarachnoid. Yeah, that's definitely. And what's the kind of imaging type?
I think it's an occipital lobe, or like
Yeah.
posterior postular.
Anything else for neuro? What about if they weren't oriented? Shoulder, stroke?
Or just like,
Yeah. Yeah. Can I clarify press? Yeah, so it's posterior reversible. Is that called?
Yes.
Yeah.
Okay, I did.
Yeah.
That's okay. It's not a term I knew in medical school. I learned it when I started rotations here.
I think that's a good covering of the neuro. What about renally? Anything you're thinking about with high blood pressure? Sort of CKD.
What if you got a urine sample and it had a lot of RBCs? What would you be thinking about? What syndrome? Nephritic syndrome, yeah. Or PGN specifically.
We can move on to cardiac. We worry about the patient with the very high pressure. Chest pressure. Yeah, airway dissection, ACS, all good points. What I guess is pointing away from aortic dissection for this patient. What symptom is not happening? Yeah, pain radiating to the back, tearing pain. Yeah. What other ones? Cardiac, okay, pulmonary. What are you worried about?
He doesn't have it yet, but you could like flat pulmonary picture.
Yeah. Anything from an opto perspective that you think he might have based on his findings? Really high blood pressure. Yeah, hypertensive retinopathy. Yeah, broad differential. There are a couple of other things I want to touch on. So we talked about, he's maybe not taking his antihypertensives, so that's a reason why it could have exacerbated his hypertension. He's also maybe withdrawing from opiates. Could be drug induced, so he has cocaine use history. We talked about PRES, hypertensive encephalopathy. Hit on a lot of these. Cardiac findings, pulmonary findings, and there are a few from endocrine that we didn't talk about, but he could be having hypothyroidism, and things pointing to that could be tachycardia, tremors, sweating, diarrhea, but he doesn't have any of those features really. And then Cushing syndrome is another one that can present with really high blood pressure, but they would also have these findings of moon face, weight gain centrally, in extremities, some skin findings, fatigue. So a few things to keep on the differential, but not necessarily super high. So what other testing would you want to get? What labs would you want to see for this patient if you're admitting him? Yeah, CBC, BMP.
EKG.
For his chest pressure, anything to rule out? Yeah, tropes. Yeah, chest X-ray. For the neurologic stuff, what would you get to rule out? Like a hemorrhage, or
CCT.
yeah, CT head, yeah. And then for his drug use, maybe urine drug screen, UA. So for his CBC, it's within normal limits. For his BMP, he had an elevated creatinine of 2.1. His BUN's 38, K is borderline 5.1. His LFTs are normal. His tropes initially elevated to 26 but came down. His urine drug screen is positive for fentanyl, opiates, cocaine, and then his UA is positive for 2+ protein, no RBCs. And then his EKG is here. Does anyone want to take a stab at interpreting it? Is he having like a regular rate, would you say? Yeah, regular rate. Narrow or wide QRS complexes? Narrow, yeah. Does anything stick out to you with these like overlapping QRS complexes? Yeah, VH. And then they also noted some T-wave inversions in leads 1, 2, and 3, and 4, 5, and 6. So on additional imaging, so I'm going to ask for a chest X-ray. He has mild emphysematous changes, no infiltrates. On his head CT, no acute hemorrhage or infarct. On fundoscopy, as we mentioned, this is what we're seeing, no optic disc edema. And then on his TTE, he had an EF of 60 to 65%, concentric hypertrophy, no other findings. So based on all of this information, I think there are multiple problems going on, but I guess what are your 2 top causes for his presentation? Like a uniform diagnosis for him.
Hypertensive emergency.
Yeah, hypertensive emergency in the setting of yeah. Withdrawal. Yeah. And so, yeah, hypertensive emergency in the setting of withdrawal and underlying untreated hypertension. So there are a few teaching points that I wanted to go through. The first is differentiating urgency versus emergency. So both exist under this umbrella term of hypertensive crisis, and it's defined by a systolic blood pressure greater than 180 and a diastolic blood pressure greater than 120. And urgency is when you have no end organ damage. Emergency is when you do. So as we discussed, he has a couple of findings of end organ damage. It can be signs of stroke, hemorrhage, hypertensive encephalopathy for the neurologic standpoint, as we discussed, aortic dissection, ACS, left ventricular failure. And then he has some signs of hypertensive retinopathy. He also has maybe signs of an AKI given his elevated creatinine. Other signs from a renal perspective could be decreased urine output, hematuria, proteinuria. And I just wanted to touch on hypertensive retinopathy a little bit more. So there are 3 phases. Starts with a vasoconstrictive phase. There's retinal arteriolar narrowing and vasospasm. And then the sclerotic phase is when the arteries start to thicken and you can see AV nicking, copper wiring, which I can show in a little bit. And then the last phase is exudative, where the blood vessels are actually breaking and releasing fluid, causing findings like flame hemorrhages, optic disc edema. So this is actually a patient that I saw at Emory. He came in with a blood pressure of 270 over 160. And this is what his fundoscopic exam looked like. So there are a couple things to note here. This is the right eye. This is the left eye. Sorry, this is the right eye, left eye. This is the optic disc. And usually you should be able to kind of trace your cursor around the edge, but you can see that it's kind of fuzzy here. Same with the left side. So that's optic disc edema. So already it's an exudative phase. And then you can also have macular exudates, which is fluid collecting in the macula, which is responsible for our central vision. And then there are other findings of cotton wool spots here, and then a flame-shaped hemorrhage here. And you can also sort of see AV nicking here. It's kind of like the vein is disappearing when the artery crosses over it. And so just to go back to him, he really only came in with a headache, and he mentioned that he was having like an increased blind spot in his right eye. So hypertensive emergency can present in many different ways, and should get a full history. So going back to the hypertensive crisis, the overall workup is what we mentioned. You get full set of labs, CBC, BMP, tropes, and EKG if they're coming in with chest pressure. You definitely want to rule out any other signs of end organ damage. So getting a UA, other causes of hypertension, so withdrawal, tox screen, getting full imaging. You would start broadly, but also kind of narrow it down based off of their symptoms. And once you've differentiated whether it's emergency or urgency, you can kind of decide how to treat. For urgency, it's a misnomer. You don't always have to treat urgency. Usually you can ask to recheck the blood pressure and it will come down. But you generally want to keep their blood pressures below systolics of 160 and diastolics of 100. And you try to reduce it over hours to days. You generally don't introduce new antihypertensive meds. You'd much rather use their home meds and maybe increase their dosage if needed. And overall, a few studies have been done showing that treating hypertensive urgency with additional medications can lead to worse outcomes. So they found increased instances of AKI and other signs of end organ damage because the body is maybe generally adapted to a higher blood pressure. And when you lower it too much, then the organs can become relatively hyperperfused. For hypertensive emergency, it requires ICU level care. So there are different goals for MAP reduction within the first hour versus the second to 24th hour. In the first hour, you want to reduce MAP by 10 to 25%, and then 5 to 15% in the following hours. But there are certain situations where you don't decrease the blood pressure, and that's if the patient has an acute ischemic stroke, intracerebral hemorrhage, and you might decrease the blood pressure even more quickly if they're having an acute aortic dissection. Does anyone know why you might not want to reduce blood pressure in acute ischemic stroke or hemorrhage?
Because the blood pressure is high, compensate to reduce the rate, so or that.
Exactly. Yeah. And then the antihypertensives that we consider starting are IV vasodilators and IV adrenergic inhibitors. So that's nicardipine, nitroglycerin, hydralazine. And then the adrenergic inhibitors are labetalol, metoprolol, phentolamine. So for this patient, he was eventually administered oral clonidine 0.3, and the AD didn't really improve his blood pressure. He couldn't get beta blockers due to his cocaine use history. Does anyone know why that's a contraindication? So cocaine is, it basically blocks the reuptake of norepinephrine. And norepinephrine stimulates alpha-1 receptors and beta-2 receptors. So alpha-1 receptors lead to vasoconstriction, and beta-2 receptors lead to vasodilation. So if you're giving a beta blocker, it can cause unopposed alpha-1 stimulation, and that would lead to worsening of his blood pressure. So he was eventually started on a nicardipine drip and then admitted to the ICU. After a few hours, blood pressure came down to 162/98. His creatinine came down, K normalized, and his symptoms improved. And then his nicard drip was weaned off. He was started on oral diltiazem, hydrochlorothiazide, eventually started on methadone, and he ended up going to an inpatient rehab facility. So the main takeaways that I want to emphasize for my talk are hypertensive urgency and emergency are differentiated by whether there's end organ damage. Most often, hypertensive crisis is due to medication noncompliance, as with this patient. If you do take a look at their eyes, you would notice AV nicking, copper wiring, optic disc edema maybe. And there's no immediate treatment for the eye findings. Really, it's just follow-up outpatient to make sure that it's resolving. And then treating hypertensive urgency, usually you don't treat it or you use their home meds. And for emergency, you would use ICU level care and additional meds. So that concludes my intern report. Thank you so much.
Yeah, for that patient that you saw in Emory, were you able to examine them again in the clinic, or did you ever have like any follow-up? Did you see resolution of the
Yeah,
side
I think it
findings?
came every checked and gradually it resolved. So no optic edema. The hemorrhages that we saw were gone. We had good vision. Yeah. I got it.
I just have a question back.
I have a question about, I guess this is fresh in my mind because we had a talk with Chris yesterday about, like, when do you need certain labs and when do you not? Why do you need a CBC in this case for this patient? If they were coming in with altered mental status, I understand wanting to rule out like sepsis with a white count, but if they're not, like, I know it's just like you've never admit someone to the hospital without doing the CBC, but like, why are we actually doing it?
Yeah, I mean, that's a fair question. I guess assessing for like a drop in hemoglobin, like possible bleed somewhere in addition to having the side.
I would say the initial CBC is probably going to be the most helpful for you because you're still teasing out what's going on with this patient. And if, like Nithya already said, if it's like a bleed somewhere, sure, you want to find the bleed or like get a quantification for how severe it is, the vital stability. I would say if you see the AKI and you're more worried about like nephritic or rapid progressive glomerulonephritis, you would want to get a CBC because then you might see some evidence of hemolysis and that might be taking you down a different pathway and workup. Probably though, when you have like one reassuring CBC and you kind of have the story, like for him, he's a little bit more straightforward because we know the drug use. You might not need to keep following up with the sequential CBCs, but for another patient who would walk in with a different comorbidity, maybe another one might be helpful. Dr. Goggins, do you have any insight?
No, sorry.
That's fine.
I think one thing to note that was we can start the oral anti-cancer regimen. I don't know if you pointed out already, but I've seen before people just put them on grapes and then
Yeah.
take them off. Because we didn't start that one. So
My also biased view is I think sometimes we're very conservative for a very long period of time in the ICU for some of these patients. I think we can be a little bit more aggressive because by the time, if you're looking at like their map goals, by the time they're coming up to the unit, an hour or two is already passed. So they've already had that like 25% initial reduction. I find that we're oftentimes prolonging that conservative gradual period, which might make sense for the patient who's had prior stroke, CVAs, or other comorbidities. But for another patient who doesn't have like a long list of other comorbidities, you're probably okay with being a little bit more aggressive. So that's just like my limited experience that I found in the ICU as a resident. I felt like we kept people on drips for too long.
I think it's important to just like update your order parameters because like the nurses are going to go based off of what you have as the map goal. So if you're yourself not changing the map goal from that like 15% reduction in the first hour to like 24-hour, 25% goal, they aren't going to change it. So they do get stuck in the ICU for like longer than they do.
So I understand obviously keeping blood pressure, kind of the way it is for an ischemic stroke, but for hemorrhage, why wouldn't you try to lower it? I think that was somewhere that's like.
Yeah, I think my understanding is you're having a hemorrhage somewhere. You can also be having a blockage somewhere else. So you don't want to drastically reduce the blood pressure and reduce perfusion of that area, although we don't know where it is.
Okay.
Also, if you think about it, that bleeding, they're probably more often than not going to get some sort of procedure, whether if it's like a bleed in the brain, they might be going down, taking neurosurgery, and they're going to have to undergo maybe intubation, maybe other sedatives that are going to cause hypotension. So if you're already working with like a tight window of gap, that's going to kind of set the stage for like a more dramatic, atherogenic insult, probably most likely stroke. But be careful with antihypertensives. I think I was mentioning this with Colin's team yesterday when we were talking about AKIs. ATN caused by our own interventions on patients by having too strict of a blood pressure goal. I have seen like recrudescence of old strokes because people have like tried to shoot for that target 120/80. Like Nithya, I'm glad you made that point. Some of these patients are living so chronically high in the outpatient setting. You want to get an idea of that. Like they're chronically using cocaine or other vasoconstrictive agents. You really want to be careful because you can do a lot more harm just by trying to shoot for that gold standard, like 120 over 80. Hey, great job, Nithya.
That's good still.
Oh, shoot.
I'll just go over hers again.
Yeah, you're actually gonna go over hers, and I'm gonna see how much you were paying attention. Where's the minutes?
And sorry.
There she is. Why is it?
There's the dragon.
Oh, you know what? It's because I have to share the screen for your presentation. And I have to drink. There we go. That should be nice. You just let me share here.
Dramatic.
Yeah. Okay, get rid of this little toss guy. All right, we're switching gears a little bit, guys, for the second presentation,
Okay.
which Ian will take us through.
Happy Friday, everybody. For those of you who I have not met yet, my name is Ian. I'm one of the categorical internal medicine residents. Please ignore the dramatic title. I wanted to keep this somewhat of a mystery and keep people engaged. The presentation is going to go a lot like Nithya's. So first, we're going to talk about a case, a patient that presented here to Pennsylvania Hospital at the emergency department, so an undifferentiated patient. We're going to talk about how to build out the differential for an undifferentiated patient like this. From there, I'm going to start talking about the testing that went on for this patient, both labs and imaging, as well as the testing that we do for patients with this disease process. From there, I think it'll be pretty clear what the diagnosis is. We're going to talk about classic findings of the disease, as well as the pathophysiology, followed by some clinical pearls, as well as management of disease. Also pretty informal talk. So if you want me to repeat anything, go back a slide, ask questions, feel free to interrupt. Okay, let's start with the presentation. So we've got an 83-year-old female. This was taken directly from the HPI on the presentation. So she was labeled as very pleasant, which I always think is amazing when they include a little bit of personality. Although if I saw a patient like this in the ED, I would think that's a little frightening. Pretty benign past medical history. So some hypertension, maybe borderline CKD. She came to the emergency department with recent falls, complicated by compression fractures. She was endorsing significant back pain and had started using tramadol recently. The daughter, who was present at bedside, was providing a lot of history, and she reported that her mother had been gradually more tired and fatigued, had been sleeping more throughout the day, and also had some waxing and waning confusion. So the daughter thought it was appropriate to bring her to the ED for evaluation. And her primary concern was altered mental status and confusion in her mother. So on presentation, the patient was drowsy, oriented just to herself. She was having some difficulty following commands, but otherwise not in acute distress. Before I open the floor to more questions you'd want to ask, I'll briefly talk about the vitals and physical exam as well. So blood pressure is a little high, 169 over 80. She's borderline tachycardic with a pulse of 94, but other than that, there's not a lot of information to go off of from this physical exam. So we're kind of left with, not a lot to do except for ask questions. So I'll open the floor if there's anything else you want to know about this patient. Feel free to ask. She's not on blood thinners.
Any fever, chills?
No fevers, no chills, no sick symptoms or anything like that.
How recent was the fall?
She had a number of falls over the last few months. The daughter's not always with her mom, so she's not sure the extent of the falls, if she's hit her head, or how frequently it's happening, but she does have some moderate bruising to her right side and her back.
Is there any signs of head trauma?
No signs of head trauma. Good questions. Yeah, good question. So the daughter who frequently visits her mom said over the last couple of months, she'd been more and more tired, but the confusion was what she was most worried about. And that was just in the last week or so.
That's a shame.
So the daughter doesn't quite remember. She's on a diuretic, she believes, nothing for the chronic kidney disease. So just one med for the hypertension, that's it. And the tramadol that she recently
Did she ever
started.
get any head imaging for the falls?
No head imaging yet.
When did she start tramadol?
Let's say 2 months ago.
She's been drinking a lot of water, more than she's been eating. Does she have to decrease intake of food?
Good question. Yeah, she has had a decreased intake of food. The daughter's usually the one who delivers some of the food to her mother. And she said that a lot of times the food and drink sometimes goes uneaten or undrinking. The daughter thinks that maybe she lost some weight, but she hasn't been weighed in a while, so I'm not sure. These are all great questions, by the way. So just in the interest of time, I'm going to move forward with trying to build out our differential. Because it's an undifferentiated patient, I think we have to start very broad. I know an easy way to do it is either by organs, like how Nithya brought it up, or we can use the mnemonic, so we're going kind of system by system. So using the Vindicate mnemonic, which I know is a popular one, let's think of maybe some vascular pathologies that could be causing some of the symptoms that we're seeing in this patient. Can anyone just shout out a couple that come to mind?
Vascular dementia, like chronic strokes.
Absolutely, yeah. Vascular dementia is a big one. Yeah, hemorrhage for sure. Bleed in the brain. Stroke. I also put pulmonary embolism there too, just because in the physical exam it talked about like a poor inspiratory effort on the lung exam. Also borderline tachycardia. We didn't know if maybe she's been immobile for quite some time. So definitely something you want to be still like ruling out or ruling in. Okay, in terms of infectious causes, I think this is pretty general. I think a lot of things can cause confusion or drowsiness, especially in an 83-year-old or geriatric population. I know we got a talk from pharmacy and infectious disease recently that actually talked about how like confusion or delirium actually isn't the most impressive sign for like a UTI in this patient population, but something you still want to be considering. Also for like neoplastic, I think so many cancers can present with neurological findings like this. So I'm going to kind of leave this as just still a broad category. Can anybody think of like some degenerative causes maybe of patient's condition?
Alzheimer's.
Yeah, I would say Alzheimer's degenerative. Absolutely. You know, we don't know necessarily if this has been going on for months, if there's like a stepwise decline in cognition. I mean, she's definitely of the age. Anything else?
It's also possible these symptoms that we're seeing are different diagnoses. So even though, you know, when we go through cases like this, we're thinking of one underlying diagnosis. More often than not, we're working with gray cases in the real world, and a lot of one diagnosis might not fit everything together. So she might be having falls, she might have confusion, but this one diagnosis might not explain everything.
Absolutely. So in that same vein, she could have like an Alzheimer's-like picture. There could be some dementia, some vascular dementia that's impacting, I think, a lot of her drowsiness. Also, you know, she could have osteoarthritis. That could be, I think, a factor in a lot of her like joint pains causing some of the falls, osteoporosis. She had some chronic kidney disease. Maybe there's some like calcium, vitamin D imbalance in this patient. So that's, I think, a fair number of degenerative. Can anybody think of some like iatrogenic causes for drowsiness? The tramadol, absolutely. That's an opioid medication. So we don't know how frequently she's taking the tramadol. If it's something that she's using too much, it can be a big sedative. Absolutely. I'm gonna skip congenital because we're not giving this talk at CHOP here. So she's also 83 years old. In terms of autoimmune conditions like rheumatoid arthritis, that could be a component if she's never been tested for that before. Also thinking about drowsiness, maybe like a hypothyroidism picture. Trauma, I think this one's a little bit more obvious. The patient did report some recent falls. Is there maybe some kind of hemorrhage that's going on? Does she have fractures and is not able to verbalize some of the pain that she's feeling? And then the last one, which I think is a really big one, like endocrine or metabolic causes. Can anybody think of like one or two? Absolutely. So electrolyte disturbances, I think, are the big ones here. I think we talked about like poor PO intake. So low sodium, high sodium, thinking about hypercalcemia, absolutely. So in order to narrow down our differential, we need some objective data, right? What are some lab tests people would want to order for this patient? BMP, absolutely. CBC, yeah. And again, in the interest of time, I'm just going to start to outline the first information that we were getting back in the emergency department. So here's the CBC. White count, pretty unrevealing at 10.9, but hemoglobin of 8.9, so pretty significant anemia. We don't know what her baseline is, but I think even if her baseline was at like a 10 or 11, that's a pretty precipitous drop. And the BMP is extremely revealing. So sodium of 129. I could probably spend the whole hour doing a talk about hyponatremia. Is this real? Is this pseudo? You know, what's the urine osms? What's the serum osms? What's the volume status? For the purpose of today's talk, we're just going to say that the sodium's low. I'll point out that the creatinine of 3.38 is also much higher than her baseline, which is usually at like 1.5. And with a BUN of 39, looking at the BUN to creatinine ratio less than 20, you're thinking maybe this isn't pre-renal, maybe this is something that's intrarenal happening intrinsic to the kidney. and a calcium of 12.3. So hypercalcemia, we have a couple different electrolyte disturbances that could be contributing to the like altered mental status picture. I'd also say that the ionized calcium was elevated as well. In terms of imaging, if we're concerned for falls, once again, what's like the first thing that we're going to want to order for this patient? The CT head, yeah. So I'll just put some pictures up here. I know it's a little bit small, so can anyone point out what we might be looking at here? Absolutely. Lytic lesion. So here's the impression from the radiology report. Numerous areas of lucency for which lytic metastases, myeloma involvement cannot be excluded. I'm going to kind of skip the MRI head here because it just talked about some like chronic infarcts and other chronic findings. Can anybody sort to suss out the pattern that we're seeing here? Maybe a constellation of like symptoms and lab findings. I saw a little
We take dance.
crab claws going here. Absolutely. So thinking about the crab criteria for multiple myeloma, the C is hypercalcemia, for which this patient has, the R, like renal involvement, the acute kidney injury, creatinine of 3.38, the A is for anemia, hemoglobin of 8.9, and then of course these bony lytic lesions that we're seeing on imaging. So that points us in the direction of multiple myeloma, absolutely. Some other labs that were taken in the ED, a parathyroid hormone level, patient had high calcium. We want to see, is this a process that's like primary to the parathyroid gland? Is this like an adenoma or like hyperplasia of the parathyroid gland? The kappa lambda ratio, I'm going to talk about that in a bit, but high uric acid, that can be indicative of like high cell turnover. And we talked about maybe hypothyroidism being a contributor to the patient's confusion and drowsiness. That was normal. Okay. So if we're thinking about multiple myeloma, I know the diagnostic tests that get tossed around very frequently are serum protein electrophoresis and urine protein electrophoresis, the SPEP and UPEP. But actually, before you go into that, the American Society of Clinical Oncology actually recommends you get a total protein and albumin first. This initial laboratory evaluation can actually clue you in if there is like some kind of other malignant process happening. If you have an elevated total protein and a normal or low albumin, there has to be something else that's filling in that gap. So the first test that they saw here, you can see that the protein was elevated, the total protein, 14.9, with the albumin a little bit low at 2.7. And then you go into the serum protein electrophoresis. So I think this is like a pretty common graph that a lot of people might be familiar with. But just to break it down a little bit more, maybe think back to your lab days in undergrad. What an electrophoresis is actually doing is separating proteins out by charge and size. You want to characterize, what proteins are in the serum and quantify how much they are. So in a normal patient, you wouldn't have this huge spike in the gamma region. There would be a spike in the albumin region because that's the most heavily concentrated protein normally. But the alpha 1, alpha 2, beta 1, beta 2, and gamma should all be around the same height. The gamma spike is what's looking at your immunoglobulins. So in a multiple myeloma patient like this, where you see a gamma globulin level of 8.6, that's often due to like a monoclonal immunoglobulin or that M protein that's very characteristic of multiple myeloma. So that's not the only test you want to do. You want to do a urine protein electrophoresis in conjunction with the serum one. And that's because in multiple myeloma, cancerous plasma cells can produce excessive amounts of light chain as well, which isn't always visible in the serum. Sometimes it's only visible in the urine. The urine protein electrophoresis is what's actually detecting the light chains, also known as like the Benz-Jones proteins. So you want to order the UPEP to complement the SPEP. And just a little review of what the antibody structure looks like. It's made up of heavy chains and light chains. The heavy chains are larger, and that's what determines the class, like the IgG versus IgA versus IgM, versus the light chains that pairs with the heavy chains to form that Fab region, which is antigen specific. And another test that they did was this kappa lambda ratio, also sometimes referred to as a free light chain assay. So normal plasma cells will make a slight excess of either kappa or lambda, that region of the light chain of an antibody. And that ratio might be in one direction or the other. It could be like all the way up to 1 to 4 or 4 to 1, like kappa to lambda. But in a monoclonal process like this, where you have one progenitor cell that's overproducing itself over and over again, that ratio is going to be skewed heavily in one direction. And that's what we see with this patient. The kappa to lambda ratio is like 78 to 1. So that skewed ratio kind of reflects the clonality in that process that's happening in multiple myeloma. So I think, as you can tell by now, the patient has multiple myeloma, but very quickly, so we're not anchoring just completely on that one diagnosis, I want to talk about some other differentials that present similarly, or might have some overlapping features that are like characteristically similar to multiple myeloma. So in terms of other plasma cell or monoclonal disorders, monoclonal gammopathy of undetermined significance and smoldering myeloma all exist on the same spectrum of disease as multiple myeloma. So I'll be talking about that a little bit later on. Waldenstrom's macroglobulinemia will have that same characteristic M spike on the serum protein electrophoresis, or might have like a positive UPEP for the abnormal free light chains. But the differences lie in the clinical presentation. So the lytic bone lesions are much more suggestive of multiple myeloma versus Waldenstrom's. You have those hyperviscosity symptoms. Think the headaches, the vision changes, splenomegaly, things like that. Primary amyloidosis. This is something that's born out of multiple myeloma sometimes. The big difference is you usually see more end organ damage in amyloidosis. You have toxic amyloid deposits that end up in organs. Think like your restrictive cardiomyopathy. It can be in the kidney too, causing nephrotic syndromes. Macroglossia, like the big tongue, I remember was like a random feature of amyloidosis. And then POEM syndrome, I put up here. I'm not going to focus too much on it, but that's also a similar process to multiple myeloma. We also want to be thinking about other malignancies with sometimes bone marrow involvement or other metastatic bone diseases. So thinking about other cancers that like to go to the bone, there's that classic mnemonic of BLT with a kosher pickle. So breast, lung, thyroid, kidney, prostate cancers. Does this patient have a history of breast or lung cancer? Can that be, what's causing some of those other lytic lesions in the body? Oh yeah, that mnemonic. It's a good one, right?
Help before my boards, Ian. Thanks.
So week too late. Other malignancies with bone marrow involvement, your lymphomas and leukemias. What you would see in those classically are more systemic symptoms like your B symptoms, night sweats like drenching through your clothes or getting your sheets very wet multiple times a month, unintentional weight loss, the recurrent fevers, that sort of thing. Primary bone tumors, it's pretty rare in adults, especially at this age, but you do want to rule out like an osteosarcoma or chondrosarcoma. They're probably more localized. Causes of hypercalcemia. Again, this could be its own hour-long lecture in its own, but does the patient have an elevated PTH? Like, is this a primary hyperthyroid process? Is this something that's tertiary to like a long-standing CKD? Other things can cause high calcium like tuberculosis and sarcoids. So definitely want to be thinking about risk factors in that area. And then other causes of anemia plus renal dysfunction. So the patient does have like a borderline CKD. Of course, you wouldn't see something like a monoclonal spike on an SPEP, but chronic infections like HIV, that can actually mimic a lot of the things you see early on in cancer. Think about the weight loss, anemia, sometimes marrow suppression as well. HIV can do a lot of different things. Again, this patient's 83 years old. Does she have like the risk factors for like a new diagnosis of HIV? And then autoimmune conditions like lupus, again, anemia, proteinuria, renal involvement, that sort of thing. So just get back to the patient quickly. So they ended up getting a bone marrow biopsy, which showed 90% plasma cells. I'll get into why that's very significant shortly. They were immediately started on IV fluids, zoledronic acid, which is a bisphosphonate, and calcitonin. They wanted to lower the calcium levels as quickly as possible. And once there was a normalization of the calcium, her mental status actually returned back to baseline. She was then started on chemotherapy as an inpatient with Velcade, which is bortezomib, proteasome inhibitor, daratumumab, which is a monoclonal antibody, and dexamethasone. It's a pretty common triple therapy for multiple myeloma. We'll talk about management shortly. And then was also treated prophylactically with allopurinol for tumor lysis syndrome, had a normalization of her uric acid, and then was discharged to rehab after only 3 weeks in the hospital. So let's move on to like some educational content of multiple myeloma. This is going to be pretty like bird's eye view, high level, just in the interest of time. But in order to diagnose multiple myeloma, the American Society of Clinical Oncology have 2 criteria that must be met. So the first actually is a bone marrow biopsy related criteria. So you need to have clonal bone marrow plasma cells, at least 10%. That's proven in the biopsy. And then any one or more of the following myeloma defining events. So think about the CRAB criteria. And this patient actually kind of checked the box for all of the CRAB criteria. So because she had this box checked and multiple of these box checked, you only needed one of them, that would have been enough to diagnose with multiple myeloma. I will say though, one of the other criteria for a myeloma defining event is marrow plasma cell percentage of greater than or equal to 60%. So even if she had no CRAB features, having the bone marrow biopsy that was showing 90% plasma cells, that was enough to diagnose her with multiple myeloma. And then we talked about the FLC ratio, that's the kappa to lambda ratio. This has here greater than or equal to 100. She had 78 as her ratio, so that wouldn't be enough to check that box, but that is an interesting thing to keep in mind. And then just some risk factors for multiple myeloma. So the average age or the median age of diagnosis is between 65 and 70. So risk does increase with age. Slightly more common in men, slightly more common in like African-American populations compared to being lower in Asian populations. In terms of like family history, first degree relatives with multiple myeloma or even MGUS are at like an increased risk, but it's not that substantial. In terms of like a germline predisposition, like certain inherited mutations, those aren't really risk factors, as well as chromosomal abnormalities. That can be like prognostic, but again, it's not really like a risk factor if you were born with those. So let's talk about the CRAB involvement a little bit. And this is something I didn't actually understand myself until I was doing a little bit of research, like why does malignant plasma cells, why do they cause hypercalcemia? And that's because malignant plasma cells secrete osteoclast activating factors, specifically rank ligand and interleukin 6. So rank ligand, as we know, stimulates osteoclasts and inhibits osteoblasts. So you get that excessive like bone resorption, calcium is released into the bloodstream. That's also why we see the lytic bone lesions. We're breaking down bone. In terms of the renal involvement, so when free light chains exceed the reabsorptive capacity of the kidneys, they can obstruct distal tubules in the kidneys, raises intraluminal pressure, you get injury, you get inflammation, all that fun stuff. And then in terms of the anemia, this is like a bone marrow infiltrative disorder. So you can think about your bone marrow kind of like a garden that's going a bunch of different crops. You've got like your crops growing your red blood cells, your white blood cells, your megakaryocytes with your platelets. If you have a weed like a cancer or blood dyscrasia, some kind of monoclonal process, that's going to crowd out normal production of your other cells. So you're doing a worse job at producing your red blood cells in a healthy way. Also, if you've got renal dysfunction, maybe there's some decreased EPO. It could be like a multifactorial process there. So now moving on to the spectrum of like MGUS to smoldering myeloma, you can think of this more or less as like, is there the presence or absence of end organ damage? So in MGUS, like really the definition of it is less than 10% of clonal plasma cells in the bone marrow and no CRAB features, no symptoms whatsoever. So oftentimes this is found incidentally. And the progression risk to multiple myeloma is pretty low. It's only at like 1% each year. So if you have like 100 patients with MGUS, maybe in the course of a year, one patient would progress to multiple myeloma. Smoldering myeloma, you have more clonal plasma cell involvement, like sometimes greater than 10% in the bone marrow, but still no CRAB features and still no myeloma defining events. So again, this is something that's asymptomatic. And then as soon as you get some symptoms, that's when you have like full-blown multiple myeloma. I thought the staging was a little bit interesting for multiple myeloma, just because it's very unlike solid tumors, which are staged, classically by the TNM model with tumor size, lymph node involvement, and metastases. The American Cancer Society uses this revised staging model, which is more along the lines of tumor burden and disease biology. So it's more of like a prognostic indicator. We're really looking at beta-2 microglobulin levels, albumin, cytogenetics, and LDH levels. And it's just a helpful way to stratify risk and like predict prognosis. You can see that there's no stage 4 here. So if you're just like reading about a patient or you have a patient of your own that has like stage 3 multiple myeloma, that's pretty extensive disease. And the prognosis might be pretty poor compared to like a stage 1. And stage 2 is just kind of like the intermediate in between. And then also just a brief overview on what treatment options look like for myeloma patients. So in the 70s and 90s, when we were still trying to understand more about the disease, we were kind of just throwing things at it that we threw at other cancers, like other cytotoxic and chemotherapeutic agents, usually alkylating agents like cyclophosphamide and corticosteroids. It's pretty modest survival benefit in the 70s and 90s with those agents. So only like 2 to 3 years, the median survival was after time of diagnosis, that time range. In the late 90s and 2000s, that's the advent of autologous stem cell transplantation. Usually that was just given to patients who are refractory to initial treatment, but they started to introduce immunomodulators like lenalidomide, which is still like a mainstay maintenance therapy for a lot of these patients, and the proteasome inhibitors like bortezomib. And then in the 2010s, we have monoclonal antibodies, like this patient who got daratumumab. That's a monoclonal antibody with the target of CD38, which is highly expressed in malignant plasma cells, as well as elotuzumab, which is a CD319 target, also on like malignant plasma cells. So we can see why that's pretty efficacious target. And then moving to the 2020s and today, CAR T therapy. So CAR T has kind of been this amazing like therapeutic development for tons of different cancers, primarily like bone marrow related cancers. And the whole concept of engineering autologous T cells with chimeric antigen receptors against like the specific myeloma antigens that a patient has been really amazing. And the median survival now is between like 8 to 10 years for people diagnosed with multiple myeloma. So I will say that in terms of like what a cure looks like for multiple myeloma, that's kind of like an elusive word that I think, doesn't necessarily make sense with a lot of cancers. What we really look for is complete remission, which is more so defined by the absence of like detectable monoclonal protein in multiple myeloma patients. That has been achieved in like a substantial proportion of patients, but what we do see is like relapse after a certain amount of time. So the conversation has shifted a little bit more towards like from absolute reduction, maybe more towards like disease control now with a pretty normal life expectancy. So median survival of 8 to 10 years, if you think about when the average age of diagnosis is of like 65 to 70, these patients are living pretty normal lives, albeit with like pretty normal testing and labs with their oncologists. So that's pretty much it for multiple myeloma. Thanks everyone for listening to me ramble. Any questions?
I have two side comments to make.
Yeah.
Less specifically with myeloma, although it's like one of my favorite topics in the nephro world. Your K to L ratio that you guys send on patients, you might have like an abnormal. Do you know how it have you guys seen like the KL reported out? They'll give you the K level or the kappa lambda, and then they'll give you the kappa to lambda. This is like where the money is for like looking for the monoclonal gammopathy of significance. But you might have patients that have elevated kappa or elevated lambda, and that's normal-ish. It's not like an abnormal finding. This commonly happens with CKD patients. So if you have say, I don't know, you're working up an AKI and the nephrologist asks you to sign this, you see that the ratio is fine, but these are abnormal, that's still relatively okay. It could be a common normal-ish finding for a CKD patient and some other autoimmune conditions like rheumatoid and stuff like that. And then the other point I'll make is, Ian had mentioned the monoclonal gammopathy of undetermined significance. Another notation that you might see or come across in like the nephrology notes is there's this whole new terminology now for patients who fall in the spectrum, but they are found to have CKD that might be because of that monoclonal gammopathy. It's like a whole newer classification that is really more known in the nephrology world. And that those are called monoclonal gammopathy of renal significance, meaning that no other organ is affected besides the kidneys. And that goes into a whole pathologic breakdown of all these different syndromes. So you might see NGRS be written on some notes. We've had a couple of cases in the last couple of years here come up that are interesting. They end up getting both bone marrow biopsy and renal biopsy. This can only be proven after renal biopsy. Anyway, my one's great. Not from the patient. It's like kind of like the most internal medicine diagnosis because you have the electrolyte findings, musculoskeletal bone findings. Questions?
When you're looking at remission, are they just looking at the kappa lambda?
Yeah, honestly, I am not 100% sure. I feel like I'm not a great expert on multiple myeloma, but I do think looking at disease burden things like what is the monoclonal protein spike, is it still at that like elevated? For this patient, it's like 8.6, or is it starting to come down a little bit to like a more normal?
I think it's multifaceted, pathologic, like fractures, following up on lytic lesions, but they do follow the K to L ratio in the outpatient settings.
General.
Yeah, so the patient who I presented on last year for my CPC, the NGRS, she follows with Dr. Ford, and I think she's gone through CAR T now at this point. But what she was doing was seeing her every so often when she was getting the initial chemotherapeutics and following that K to L ratio to see if it was responding, because she had an overproduction of light chains. And once that ratio normalized, they were thinking that she was more in remission. Okay, so it can be a helpful serologic marker. Nice round of applause for our.
Okay, yeah, good luck.
Before everybody leaves, I have some social announcements as well. There's some banners here. Coming up in October, our first event is gonna be the Eastern State Penitentiary, and then